This is Martin Della Pressa with a standard DMEK case. It is continuous with the speed modified for an improved viewing experience. Here we have Fuchs endothelial corneal dystrophy being treated with a DMEK, an optical zone marker is used to delineate where the graft will be placed, and paired superior and inferior paracentesis are created. The anterior chamber is filled with viscoelastic, and a crescent blade is used to create a corneal tunnel for improved wound strength. A keratome is then used to enter the anterior chamber. Reverse Sinski is used to score the peripheral Descemet membrane along the previously marked optical zone. Then care is taken to bring in this membrane from peripheral to central, taking care to ensure there's no tears in this membrane. Once that membrane is brought all the way temporally to the wound, it is able to be removed in one piece. However, there is residual tags left. These are then stripped and removed. Air can then be used to better visualize the inner layer of the cornea to ensure that there are no tags remaining. At this time, a 10-0 nylon is placed at the temporal wound for improved efficiency in securing the anterior chamber when the graft is placed. The viscoelastic is then aspirated from the anterior chamber, and the wounds are hydrated with BSS. The DMEK that has been preloaded in a cannula is injected into the anterior chamber, and care is taken to decrease the intraocular pressure prior to removing the cannula to ensure there's no reflux of the graft. The 10-0 nylon is then tied with a slip knot. This ensures that the graft stays in place while it is being unscrolled. The graft is then positioned with cannulas. The anterior chamber is shallowed to ensure that these tapping techniques are able to unscroll the graft and center it. Here we have peripheral marks showing that the graft is reversed, and so BSS is instilled into the anterior chamber to flip the graft right side up. The graft is pinned again, chamber shallowed, and with gentle tapping techniques, the graft is unscrolled and centered into position. Once the graft is centered, then SF6 gas is placed into the anterior chamber to secure the graft. The anterior chamber is then filled with BSS. To an appropriate depth, and then a fluid gas exchange can be performed, raising the intraocular pressure to ensure that there is no interface fluid between the graft and the host. The wounds are checked to make sure they are watertight, and the 10-0 nylon is locked, cut, and rotated. After 10 minutes of high intraocular pressure to allow time for the graft to adhere to the host cornea, then they have a gas fluid exchange. This ensures that there's no gas left behind the iris, which would be a cause of angle closure. Once all the gas is brought into the anterior chamber, the anterior chamber is slightly deepened and the bubble is enlarged to ensure that there is enough to keep the graft firmly against the inner cornea as the endothelial cells begin to function. Thank you for watching.